Good afternoon, everybody. I have to bring this back to the beginning, although maybe it might be better if I started in the middle of my talk. I just want to say thank you so much to the speakers who came before. It's again, you're sort of holding your heart in your hand while listening, and with the wisdom and the honesty, I'm just deeply grateful. And sorry, I'm just going back to the beginning. I don't know. I got to get to the beginning. Okay. That would be a problem for me. Although I can read Hebrew, I just don't know what I'm reading. Here we go. Okay. That's called learning Hebrew in the United States for your bat mitzvah. It's like, that's a bet. That's a yud. That's a dalet. That's a gimel. Anyway. So it's a pleasure to be here. I'm going to be talking about shared decision-making, which in some ways can be part of the way to address this tremendous confusion. But before I start, I just wanted to share a little bit of my own kind of thinking and experience. So folks who heard me yesterday at another conference learned that I have a brother with schizophrenia to whom I was very close throughout most of my life. And right now, he's not done very well. He spent most of the last probably 20 to 30 years in a psychiatric hospital in New York. And incidentally, if you asked him, where does he want to be, he would tell you he wants to be exactly where he is. He likes it, actually. But he's not doing well. He doesn't speak very much. So it's actually hard to know what he's thinking. He clearly has some neurological frontal lobe problems. I'm not going to go into the details. You don't care. But I see him maybe every month, and we talk, Donna and I talk, and so we look at him and interact with him, and I say, well, how did we get here, And sort of roughly speaking, there are sort of three competing hypotheses that we don't know which one is true or whether they're all true. But one is how he is now is in some sense the result of all the medications and treatments he's taken. So which have not been great for his brain, okay? But which I am convinced that had he not had access to medication, it would have been a very bad outcome. He had it was dangerous at times, and it was quite scary. The second alternative is that this is just the course of his illness. And then the third alternative is it's true and unrelated, that it's neither of those things, but that he has a third thing that has happened to him in his health. So, I guess in some ways I report that to you because what it has taught me is just to be utterly humble about the work that we do and to realize that, always there's going to be more we don't know than we know, but we have to work with what we know. And I take my hats off to the treatment team in the hospital because they work so well with him, and they don't know they don't know all the answers to those questions either. And so in some sense our job is to be human. And to bring all the knowledge to bear that we can, and to use maybe shared decision-making so as a tool. So I'll start. Okay, so I'm going to try to, this isn't going to be like case studies and using shared decision-making. It's going to be taking, taking shared decision-making from a more conceptually, and then you can apply it in, whatever work you do. So we want to understand the definition, we want to identify the components of it, and then to understand how it could be applied in decisions regarding the use of antipsychotic medications. So you'll see SDM on the slide here, and that's shared decision-making. Okay, so I guess I don't have to say from the morning we had that the use of antipsychotic medication has created some controversy. And again, I think that the scientific issues are completely real. And it doesn't much matter, how I feel and how I interpret the science, other than I completely agree that we have a lot of unanswered questions. And perhaps, and I think there's a lot of pain and rancor and rage, actually, in some ways, around the use of antipsychotics. And maybe that is partially due to the way that they have been administered and offered to people, and that what I would offer to you, and I think what the field and many people who are concerned about recovery and are concerned about being person-centered would offer is shared decision-making as a tool. And incidentally, shared decision-making is really making its way through all of medicine. It's not just a tool. I mean, in fact, some ways psychiatry has come to it somewhat later than the rest of medicine. And so what we want to do is shift the discussion from medications being good or bad to can I use medications in a way that will support my recovery. So what is shared decision-making? Shared decision-making, and I love Pat Deegan. I'm a major Pat Deegan fan. Pat Deegan is a woman who has schizophrenia. She's a psychologist, and she said to herself when she was 18 and she was hospitalized and she was told X, Y, and Z that she had to take medications for the rest of her life and she was never going to have a job or do anything important, she said, I'm going to prove them wrong and I'm going to change the mental health system. And believe me, that is what she's doing. So I'm a big fan of Pat. And she says, and she's a big fan of shared decision-making, so what is it? It's a collaborative process that allows individuals and their care teams together to make treatment decisions taking into account the best scientific evidence as well as individual values and preferences. And it is a key component of person-centered care. So here's a little diagram. We have 3 models of kind of how clinicians and providers, clinicians and care recipients interact. We have the paternalistic model, where you can see the arrow, the clinician gives information and recommendations to the patient. God, my eyes are getting worse. And there's a one-way arrow. And then there's another one-way arrow, which is the clinician just gives information to the client, and then just kind of that's the end of that, and the client makes a decision. Shared decision-making is neither of those two things. It's interactive, okay? You see information and recommendations going in a circle with values and preferences, and it's this kind of dialogue that matters, okay? Okay, so when is it relevant? And this is kind of important. I'm gonna get a little nerdy on you, but I really think this is important. Shared decision-making is not an appropriate methodology for all treatment decisions, okay? It is an appropriate methodology when a clinical situation has more than one acceptable alternative courses of action, okay? So, or when competing options exist or need prioritizations. And then I'm going to leave the last one out for the moment. But the idea here is you don't necessarily use shared decision-making when there's like one life-saving strategy, and you don't sit and debate that. Okay, it's relevant when you have 2 reasonable courses of action or more. Okay, and now I want to contrast shared decision-making with motivational interviewing. How many of you here have heard of motivational interviewing or have learned how to do it or think you kind of know how to do it? Okay, because most people are pretty familiar with motivational interviewing, okay? So let's think, how does shared decision-making differ from motivational interviewing? Okay, in providing person-centered care, which is what we want to do, a key factor is the degree to which a clinical situation has acceptable alternative courses of action or situations of equipoise. So you've heard from me already that that's where we would want to use shared decision-making. Or whether there is a clear evidence for a preferred course of action, whether there's something that's really the right way to go. And all of you, from what we've heard this morning, you're probably getting a little nervous as I'm saying that, but if we can sort of, imagine that there are these 2 different kinds of decisions. So shared decision-making supports patients in making healthcare decisions in cases where there is more than one reasonable option, and motivational interviewing addresses ambivalence to medically indicated behavior change. And so let me just kind of make this simple, okay? The goal of motivational interviewing, as you see here, is to change behavior, okay? It's to change behavior. you have someone who's, kind of using substances, and they're really, really hurting themselves, and they're struggling. And what we do in approach is to help, to try to help convince them that, to change their behavior, to stop using substances, okay? The endpoint or the object of shared decision-making is to make a decision, and they're very different, and we get them confused all the time, okay? Shared decision-making is not convincing patients to take medication, okay? That's the mistake that we make. Shared decision-making results in a decision. Implementing the decision might take some motivational interviewing, but I just want you to see that those are different things. And one of the reasons why people get confused about it is that the techniques are quite similar, okay? We use some of the same techniques in talking with people. And for those of you who are interested, there's a wonderful article by Glenn Elwyn that kind of illustrates this in greater depth. Okay. So what are the key components of shared decision-making? There's a clear decision to be made, decision-making preferences evaluated, there's shared information in a usable format, the information provides a range of evidence-based alternatives and includes the strength of evidence. So there's a decision, and we're going to talk a little bit more about decision-making preference. Not everybody wants to be involved in making the decisions to the same extent, okay? There's shared information in a usable format. So if you're giving information and it goes, it's completely incomprehensible, it's a waste of time, right? The information is relevant to the decision that's being made, and then you get into the somewhat more complex part of how you help you elicit the person's values and preferences and help them sort through the information to arrive at a decision. And I want to say that in shared decision-making, it doesn't mean everybody agrees at the end, okay? The individual service recipient can make a different decision than what the clinician recommends. Okay, so just a little bit of data because I can't help myself. Some people, when this was sort of being introduced into psychiatry, there was this, people with schizophrenia or people with depression, they don't really want to make decisions. They don't want to be involved in their decisions. So you can tell this probably wasn't articulated in meetings of consumer groups. But here's a study that looked at the participant, autonomy preference index, which is a measure of the extent to which people want to be involved in their healthcare decisions. And I think it's kind of interesting. It compares different disorders, and what I want you to see here is this is schizophrenia, this is breast cancer, this is multiple sclerosis, this is depression, hypertension, minor trauma. And what you see is the people with mental illness don't really have any different extent of decisional preference than people with other illnesses, okay? But preferences vary, okay? Preferences vary. And one mistake that we make in implementing shared decision-making is not understanding that people have different preferences. So this is actually from a study that my group did way back in Maryland, and these are actually veterans who are taking antipsychotic medications, and we asked them a series of questions. First, we asked them to rate their level of agreement. I prefer that my psychiatrist, nurse practitioners offers me choices and asks my opinion about treatments for my mental illness. And what you see here is one is strongly agree. So almost everyone said that they wanted to get information, okay? Now, knowledge. I prefer to rely on my psychiatrist NP's knowledge and not try to find out about mental illness on my own. And you see here, still the modal response is to strongly agree with that. But then you start to see levels of disagreement. And then decision. I prefer to leave decisions about my mental health care up to my psychiatrist, nurse practitioner. And here you see sort of a spread. Okay? Now, one could argue that these responses reflect sort of a learned helplessness in the context of care. So I don't want you to think that, okay, well, this is the way it is, and most people don't want to be involved or don't want to actually make the decision. All I want you to hear is that this is a dynamic process that is really individualized. Okay. So then finally, the last bit of research in this part of my talk, is to what extent do psychiatric patients feel involved in decision-making about their mental health care? So what does the data tell us? And again, I can't, I don't have representative samples from the world, but this is an interesting study that was actually done in a Basque country, and you had 1,100 consecutive psychiatric outpatients, and they were asked a series of questions about the extent to which they, about their care. And so it's just interesting. My doctor made clear that a decision needs to be made, 46%. My doctor wanted to know exactly how I want to be involved in making the decision, almost never, okay? My doctor helped me understand all the information, 90%, okay? So what I want you to see here is that there is this, some of this is going on in different places to different extents, and there's actually more research on this, which I'm not going to show you. But the point is, we have no matter how you cut it, we have a long way to go, okay? Okay, now, I'm going to need a little hand around the, yeah. So what I'm going to show you now, in my talk, which I'll probably end up having to speed up a little bit, I'm going to show you 3 video clips. And the reason I want to show them to you, wait, don't go that just yet, I'm sorry. Okay, well, actually, you can see this. All right, go ahead. What you'll see here, you can go ahead. Sorry about that. Is a screenshot of the website for my center, the Center for Practice Innovations, and we have made with Pat a series of videos on shared decision making, and you can access this tomorrow. It's obviously not in Hebrew, but it could easily be translated into Hebrew if this is something that you want. It's not working. Okay. And I was going to show you 2 minutes of a video that we make. It's for the patient, and it's sort of talking to the patient about their role in shared decision making. Okay. It should be on a Word document. Yeah, I try to be like, make it fun. So it's just, I feel like
Chapter 6. You are part of the team. When a car breaks down, we bring it to the repair shop to get fixed. The car doesn't have to do anything. It just sits there while the experts fix the problem. But things don't work that way if we've been diagnosed with psychosis. The experts who work with us can't fix us in the same way a mechanic fixes a car. Instead, the experts need us to speak up and help them find the treatment that's right for us. Hi, my name is Pat Dixon, and I was diagnosed with schizophrenia when I was a senior in high school. Like many people, when I first came for help, I was quiet and passive. I figured the doctors, nurses, and social workers were the experts. I was afraid to ask questions because I thought I'd sound dumb. I remained quiet, even if I disagreed with what the professionals were recommending. I was afraid speaking up would seem disrespectful. This strategy did not work very well for me, and I ended up over-medicated, out of school, and depressed about my lack of progress. In order to recover and get the life I wanted for myself, I had to get active. I had to speak up. I learned the professionals on my treatment team could not read my mind. They needed to hear about what mattered to me. I began to understand that my family and I were also experts. We were experts in who I was as a unique individual. We were experts in my history and what my dreams, goals, and aspirations were. I was the expert on which medication side effects were tolerable and which ones were not. In other words, I learned that when I met with my doctor or social worker, there were 2 experts in the room. When all the experts worked together, we got the best results for my recovery. Now that you are coming...
That's it. Okay. Okay, so that point here, and this goes on, it's about a 7 or 8 minute video, but it really addresses the importance of activating patients to, perhaps people who have not really learned, or have learned not to speak up, okay? Okay, so here's the three-part model for shared decision making, and we're going to go over each. There's team talk, option talk, and decision talk. All right, and so as a clinician, when I'm sitting in my office, I'm thinking, am I doing team talk yet? Am I doing option talk? Am I doing decision talk? It's good to sort of, hold yourself accountable. We're going to go over each of these, and I'm actually going to have Pat show another video with Pat in a minute, but team talk is sometimes called choice talk, all right? And again, the strategies that are used in this process are very similar to what's used in motivational interviewing, so it's active listening and deliberation. Okay, so in team talk, it's just introducing the notion of a team. We work together, we describe the choices based on the evidence available, and we offer support and ask about goals, okay? In option talk, we discuss the alternatives using risk communication principles. Let's compare the possible options. Option X has the following benefits and risks to think about. Option Y has been shown to help X out of X people. Okay, and then we go to decision talk, which is you're getting to informed preferences, you're making preference-based decisions, and how does the clinician support that? And the clinician supports that by saying, tell me what matters the most to you in making this decision. The discussion and the dialogue helps the individual sort of figure out what their values and preferences are, because that's not always so obvious, It's not always so obvious. So those are sort of the three components of shared decision making, and then I'm going to show you this is going to be Pat kind of talking this through around the antipsychotic.
Chapter 5, Doing Shared Decision-Making. Precise, three-steply basic steps in doing shared decision-making. Choice talk, option talk, and decision talk. These three steps happen within a context of collaborative deliberation that supports a person in moving from initial preferences to informed preferences. Step 1 in shared decision-making is choice talk. The goal of choice talk is making sure that people understand that choices exist. We don't want people making choices when they are insufficiently informed. The elements of choice talk include stepping back and making it clear to the individual and family that a decision needs to be made and there's more than one option to consider. An example might be, there is a decision to be made about treatment for psychosis. There are options to consider, such as watchful waiting, cognitive behavioral therapy, or which, if any, medication to use. Next, we invite the individual and supporters to participate in making the decision. Don't be surprised if folks find this invitation unusual. If people are surprised, it can help to reassure them that one-size treatment does not fit all. There are pros and cons to each option, and some will matter more to individuals and families than others. Another great way to respond if folks act surprised is to say, I need you to help me to understand what's right for you. Now sometimes people will protest and say, but you're the expert, tell me what to do. In such cases, it's important to defer closure, but not leave the person feeling abandoned or alone with a tough decision. Dr. Elwin suggests, I'm happy to share my views and help you get to a good decision. But before I do so, I want to describe the options in more detail so you will understand what's at stake. Step 2 in shared decision-making is option talk. Whereas choice talk is about making sure people know that options exist, option talk refers to providing more information about the options. Of course, decision aids can be a big help during option talk. Continuing along with our example, one good way to begin option talk is to say, what have you heard about treatment for psychosis? This gets people talking and allows you to begin to hear their initial preferences and their misconceptions. The next step is to literally make a list of the options, including watchful waiting if relevant. Then turn the paper towards folks so they can see the list. Next, begin discussing the pros and cons benefits and harms of each option. Continuing our example, we would discuss the benefits and harms associated with using antipsychotics, adjusting for gender, ethnicity, and age as much as possible. For watchful waiting and cognitive behavioral treatment, we would do the same. The last step in option talk is to teach back. Ask the person to verbally summarize what they have learned. Offer corrections as needed. Step 3 in shared decision-making is decision talk. Decision talk refers to supporting the work of considering preferences and deciding what's best. Remember that decision-making is not simply a rational process. Emotion is increasingly recognized as a critical component of human sense-making. Continuing with our example of choice of treatment for psychosis, knowing the facts of each option is not enough. Part of the work is affective forecasting, or asking oneself, what would the use of an antipsychotic be like for me? A good way to begin decision talk is to ask what, from your point of view, matters most as you consider these options. The role of the clinician in decision talk is to facilitate deliberation. Some questions that help are, what's the hardest thing about deciding? Given what we've discussed, do you have a preference about our next step? Are you ready to decide? Do you want more time? Do you have more questions? Are there more things we should discuss? Are there other people who might want to talk?
So I mean, if you really listen, to what Pat says, I mean, there's a lot of fairly radical stuff in there, you know, and this notion of what would it be like for me? You know, I'm involved in this conversation with my patient. What would it be like for me? And you know, I think the other thing that you'll see is that would that we had all this information, and we, you know, and I think I hope you're also thinking about how, to some extent, this process is going to be limited or certainly impacted by the extent to which we have this information to deliver. And I think over the course of the morning, you know, you've seen that not everybody agrees on what is known, but that's something, again, that sort of has to figure into the process. Okay, so, you know, again, just to think about this, Tom is a 24-year-old man, recently referred to the team, our team, following a first hospitalization for psychosis. He was already treated with risperidone in the hospital with good response. He's no longer psychotic, it's well tolerated. He returns for his third meeting with you and reports that he doesn't like his medication. How would you approach a shared decision-making process with Tom? And then again, it's just, if we apply this, what is important to you? What are your goals and priorities? What would you like treatment to help you with? Okay. I want you to know that we have a number of choices. And again, you could even, you know, really expand on the choices that Pat talked about: continuing the medication, lowering the dose, raising the dose, switching to another medication, or tapering the medication. And again, reviewing the pros and cons. And there I want, the last piece that I kind of want to focus on in terms of tools or decision aids. Because it's very hard for all of us to know all this information and to be able to present it in a form that is understandable, and even to implement this, because it has these very specific steps. So we have, there's now kind of a little bit of an industry, and a lot of this is available online for you guys. There are tools that help individuals make a decision by defining the decision, clarifying the options, weighing the options, and considering personal values. And they're sort of intended, you know, to support the work of the collaborative work. And so you might ask, what is the evidence that decision aids are actually helpful? And here again, there's some research popping up. And I would say that, you know, if we're really going to be rigorous and we're really going to hold ourselves accountable, we should be studying shared decision-making, actually, right? And so we've learned from the literature that decision aids increase knowledge and the accuracy of risk perceptions. They reduce conflict regarding the decision, they improve communication, and they improve satisfaction with the decision-making process. So here's my very last and sort of shorter clip on showing you some of these tools. And I apologize for sort of how choppy this is, but I think I wanted you to see that you can pull this stuff up on your own and use it. We're at 8:25.
Chapter 4, Decision Aids. Decision aids are carefully developed. The Substance Abuse Mental Health Services Administration has also developed a decision aid for choice of treatment for psychosis. This is a web-based decision aid with lots of interactive exercises and videos. More information about this decision aid can be found in your viewer's guide. Decision-making is not just a rational process. Sorting through our emotions and being able to imagine various futures for ourselves is a critical part of decision-making. Toward this end, first-person narratives can be very helpful. One great place to find first-person accounts of psychosis and recovery is at the Center for Practice Innovation's website. Here you'll find hope-filled 3-minute videos from young people in recovery from early psychosis and their families. RecoveryLibrary.com is a site I put together. It has hundreds of videos of individuals describing their recovery from mental illness, physical health conditions, and addiction. It also has lots of practical recovery tools. A fascinating site is called Health Talk. It's a very reliable resource out of the UK. Of particular note is an entire section on young people's experiences. Here is a section on eating disorders. Here's a section on cannabis use and mental health conditions. And finally, some good videos from young people with psychosis. I hope you're feeling encouraged by these wonderful decision aids. Of course, there will never be a decision aid for every tough choice that people face. Because of this, the more generic decisional balance worksheet has been developed. There's a version for use with individuals and another for use with individuals and families together. These are self-explanatory, and a demonstration video is available from your viewer's guide, along with a self-quiz, discussion questions, and links to more resources. We live in exciting times where the dreams...
So what I really want to encourage you to do is to go and find these tools, because if you download them, you're going to see actually how to do this, okay? Because it's actually a lot harder than it looks. Okay, so here's a decision guide that was made by Yara. What's her last name? Yeah, she's a fellow Israeli. She worked in the United States with a group that's has made a lot of decision aids. This is a decision aid on whether to continue, adjust, or stop antipsychotics for a person with first episode psychosis who has responded to medication. And what I want you to see here is you have these 3 choices: continue antipsychotic medication, adjust antipsychotic medication, stop antipsychotic medication. And so it says, what does this involve? What are the benefits? What are the risks? How can I lower the risks? How might this affect my usual activities? Okay? And so let's just look at one of them. So what are the benefits of stopping antipsychotic medication, since that's the subject of the day to some extent? You can avoid medication side effects such as sleepiness, uncontrollable movements, and weight gain. But what are the risks, okay? Your symptoms may get worse if you stop taking medication. Roughly 80 in every 100 people, 80%, will have symptoms again in the year after stopping medications. These symptoms may cause you to go back to the hospital or psychiatric community clinic. And I think I sort of purposely chose those things to read because some of the decision aid and the information that's communicated in it is going to depend a little bit on, in some sense, some of your perspective on the data that we've seen. Although I think most would agree, from what I've heard today, that once someone's been on antipsychotics and if they stop antipsychotics, there is certainly a risk of recurrence of symptoms. And the point here is to put this in a way that has clear language, it's easy to use, and provide some forward momentum for the decision-making process. And it doesn't sugarcoat anything. That's the other thing. I have to get some water. You know, and it's just interesting, if I step out for a minute, Pat and I had a discussion about whether the decision to use antipsychotics or not was a decision with equipoise, okay? Because some doctors, or some people would say, well, there's really no equipoise there. There's one strongly recommended, obvious preferred action. And so you start to see also that there are some issues about who gets to decide whether a decision has equipoise. Within On Track, we decided that we thought that there was reasonable equipoise, or at least reasonable alternatives, because again, there's a proportion of people who don't respond to antipsychotics, there's a proportion of people who don't need antipsychotics, and then you have all the side effects. And so together, Pat actually convinced me that this was a decision that was really appropriate for shared decision making. Okay, so here you see a decisional balance worksheet, pros, cons, taking medicine, taking no medicine, and again, this kind of a decisional balance worksheet, which those of you who use motivational interviewing will recognize, gets filled in by the person. Okay. And again, I think, I think you probably already have some idea of sort of how the details of this will play out. This is a little bit, it's just sort of the same thing, and where you place it in the shared decision-making rubric. Again, I want to show you another decision aid. This is a decision aid that summarizes the side effects of antipsychotic medications. And again, it's very simple. It will have the different side effects, and then for each of the medications, it indicates the extent to which a particular medication is known to cause that side effect. And the nice thing about this is it has it all in one place in a document that's sort of easy to digest. Here's another decision aid tool. This is, again, created by Pat. It's called Finding Personal Motivation to Use Medication. And so this is sort of, again, this notion of preferences and goals. What are some of the problems or symptoms that brought you to the clinic? List 3 things the problems or symptoms are keeping you from doing, or that you really would like to be able to do in life. And so again, this is a tool that you can use in the context of shared decision making to help an individual understand sort of what value medication might have and how it might help or not help them in achieving their goals. Okay. And again, 5 minutes. Okay. So I'm going to conclude with some challenges in shared decision making. Respecting autonomy and choice. We're just going to walk through each of these. So as again, I mentioned that often, or sometimes, depends, the provider's recommendation does not align with the individual's decision. And you've gone through this process. It's been a fair process. And what that doesn't mean that the clinician fires the patient, and it doesn't mean that the clinician scares the patient. What it means is that you make a plan. And you're supportive, yet open and clear about your recommendation, and then you use a time period to revisit progress. And again, I think that a lot of times clinicians think that when you do shared decision making, you can't have an opinion. Wrong. You can have an opinion. It's just that your opinion is a part of the process. It's not the, it's not the decision. It's your opinion. But it's very important, not to walk away if your opinion is not, selected. And again, in terms of the decision around antipsychotic medications, I think we've heard all about this all day. What are the strategies that you do then to help? And as Don pointed out in the Windering study, to minimize, if there's going to be resurgence of symptoms, minimizing the impact of potential relapse. I think working with families, if we have families that can do what you have done with your son, I mean, that is a miracle. And I've seen it, I've also seen it with other people. So it's not a miracle of one. I think it can happen, but of course, as you say, not all families can do it, and not all patients want to do it. So again, symptom tracking, designated observer or group, and safety planning as a way to anticipate danger. And I wanted to show you this, my designated observer worksheet. This is another Pat Deegan creation. This is, okay, prospectively, before we start this process, I'm going to work with you. I'm going to trust you. You're my mother. You're my father. You're my best friend. You're my aunt. and we're gonna outline sort of what we know we need to collectively watch out for, and then it's on paper. It's sort of a little version of a psychiatric advance directive. Okay, then we have acute or high-risk situations. I'm a psychiatrist. We've heard from a parent. Psychosis can be dangerous. We know that. It can be dangerous for the person. It can be dangerous for society, and we in psychiatry, we have responsibility to deal with those situations and try as best we can to keep people safe. And we know that we're very bad at predicting these things, but at the end of the day, shared decision making does not tell a psychiatrist or a provider, to abandon those responsibilities for safety, okay? So it's like, okay, I have to do both of these things. I have to listen, I have to support these decisions, but I also have to, maintain my responsibility to the best of my ability to keep things safe. Then we have the issue of capacity, okay? And what do I mean by that? If someone is very, very psychotic, and you're sitting there, they're not thinking clearly, they're not thinking straight, and you're trying to have a discussion about it, with the pluses and the minuses, and you feel like you're not even talking about what you're going to be talking about, okay? That in some way the discussion isn't focusing on the decision because the person is too ill, okay? Now, and that person may be too ill, but also not dangerous. All right, and so this is where some of the rubber hits the road in acute settings. And I think, what Pat would say and what I think is, first of all, don't make assumptions. What I hear too much is, well, that person has psychosis, therefore they can't make a decision. Wrong, okay? So part of this is establishing, that most of us are sort of a little bit competent or a lot incompetent all of the time, all right? So the mistake would be to say, okay, be categorical about it, and that would be wrong. At the same time, there are situations that I think, I've certainly been in them myself, where you feel like this decision-making process isn't really real or valid, okay? And honestly, I'm not going to tell you what you do in this. I think what you try to do is you honor the person's, you try to find some way within this process that you can honor the person's desires and preferences. And then we have, this is like the other big elephant in the room, liability and responsibility. And again, it's related to some of these issues. Psychiatrists worry. We, and I'll say we because I'm a psychiatrist, are the ones that are, may be in trouble when there's a bad outcome, okay? And I'm just going to call it like it is, all right? But then, at the same time, dangerousness is impossible to predict. At the same time, problematic and severe side effects are impossible to predict. And I would just say the way I sort of think about this is where doing this, which again I think is an ethical imperative, shared decision making, requires peer and administrative support and good documentation skills. In other words, if you feel like you're not able to make this happen, then go get help. And I mean the psychiatrist. In other words, get a consultation. Don't just, and this is, we talk about the responsibility of agencies. If we're going to be doing this, we need to have agencies that have strong leadership that will support their clinicians for doing this, okay? And then I know I'm out of time, but there are a number of other issues and considerations when using shared decision making. Sort of health literacy. Again, many of these conversations are fairly sophisticated and conceptual, and many people, you have to try to adapt the conversation to the literacy of the person. Numeracy skills. Humans, we're terrible at estimating risk. And so again, this is all about how do you deal with this? You check back. Have the person tell you what you think they heard. Culture is very important here in terms of decisional preference and actually overall preferences. And then, certainly in the early psychosis space, when you've got young adults, the role of family is very complicated because you have young adults who are asserting their individuality and autonomy, and yet you have families who in many cases are the ones who are going to be there dealing with the consequences. So in summary, I just say shared decision-making is a structured approach, and I hope you got that there's very clear pieces of it to enhancing person-centered care. It is relevant when there are decisions that reflect equipoise, and I guess it matters who gets to define when there's equipoise. All stakeholders, including clinicians, including patients, families, have to work at doing it well. And then in terms of the future, I think it's fairly obvious from this morning's presentation that we need more and better data about the impact of antipsychotics. The more we know about some of the questions that were raised before, the more information we can convey. That the training of providers must include teaching appropriate communication skills. And there are some tools out there, how you do this better, and again, the use of decision aids, and again, on the client side, client activation, and really trying to promote involvement in decision-making of our clients. Thank you.